I'd like to thank the sponsors as well as the organizers of the CLASS Symposium for extending an invitation to our optometry school to participate in this year's symposium. I'm going to present two cases today. The first is a scleral lens case. The chief complaint is a 58-year-old white female patient with reduced vision along with contact lens discomfort, specifically scratchiness and foreign body sensation, who experiences pretty consistent coating of her lenses each day. Her contact lens history is that she has worn gas-permeable corneal contact lenses for 22 years, both single vision and multifocal designs. She's currently wearing a pair of 3-month-old Blanchard Reclaim multifocal gas-permeable corneal lenses. The lenses have to be removed, cleaned, and reapplied several times each day. Her eye history is that she's been treated for at least 10 years for severe dry eye, and to quote the patient, "I own every over-the-counter type of artificial tear in the pharmacy. None of them has relieved my symptoms. There's also," end of quote, "there is also a history of amblyopia in the left eye. No reported allergies to medications, but positive allergies to dogs, cats, pollen, dust, and horses. Medications include metformin for type 2 diabetes, paroxetine for anxiety, and pravastatin for cholesterol. Her medical history is positive for type 2 diabetes, times 4 years. Her last A1C was 6.1, hyperlipidemia, and depression. The patient's unaided visual acuities were a right eye 2200 pinhole to 2060 minus at near 2050. Left eye 2320 pinhole to 2100, near vision 2200. This is her form map refractive display from the Oculus Pentacam. It is absolutely unremarkable. This is the right eye and the left eye, typical with the rule topographic axial map. Nothing to comment on there. Her pupils were equal, round, regular, and responded to light, both the right eye and left eye, with no APD noted. Her motilities were orthophoria at distance and 4-prism diopter left, exotropia at near. Her extraocular muscle movements were smooth, accurate, full, and extensive. Confrontation visual fields were full in all quadrants in both the right eye and the left eye. Refraction was as follows: right eye minus 350, minus 2, axis 168, correctable to 2020 with an add of plus 2, correcting near vision to 2020. Left eye minus 4, minus 2, axis 11, correcting vision to 2060 for distance, an add of plus 2, correcting vision at near to 2040 in the left eye. Slit lamp evaluation was positive for makeup debris, anterior blepharitis along the superior eyelids in both eyes, positive trace capping of meibomian glands in both eyes with posterior blepharitis. Meibomian gland expression was minimal to absent in both the right eye and the left eye. There was a pterygium on the nasal aspect of the right eye and a pinguecula both in the nasal and temporal aspect to the limbus in the left eye. There was 0.5 to 1 millimeter temporal and nasal limbal pannus or neovascularization in both the right eye and the left eye. Fundus examination was unremarkable in both eyes with no evidence of diabetic retinopathy. Assessment: type 2 diabetes times 4 years without any indications of retinopathy, OU. 3+ bilateral dry eye, meibomian gland disease, both left and right eye, and amblyopia of the left eye. My plan was to try to solve both of her visual complaints and her dry eye complaints with one lens. So I ordered her a Valley Contacts Aurora multifocal scleral lens with a +2 add and a 15.8 diameter millimeter diameter. On the first follow-up visit, the patient stated that distance vision was good with the lenses, but there remains blurred vision at near. She's still bothered by her dry eye symptoms. They're still severe and were not improved while wearing a 15.8 millimeter scleral lens. Her acuities with the contacts were in the right eye 20/25, no over refraction. She accepted a +1 over refraction at near, but vision was no better than 20/30. Left eye was 20/50 at distance with no overrefraction. And again, the patient subjectively accepted a +1 overrefraction at near, but that improved near vision only to 20/40. She was wearing the lenses 7 to 8 hours per day with discomfort in both the right and left eye. And in fact, I found that the addition of more added near created a compromise in the patient's distance vision in both eyes. The plan was no further increase in the near add of the lenses due to potential compromise in distance vision, but I prescribed Xiidra, which is lifitegrast ophthalmic solution, 5%, 1 drop, 2 times a day in both eyes for treatment of dry eye. On the second follow-up visit, the patient was no longer interested in wearing multifocal lenses, just wanted me to concentrate on relieving her dry eye symptoms. I decided to refit the patient with Boston Sight Scleral lenses. The specifications are shown, are displayed here for you. Please note that the overall diameter of the scleral lens was increased from a previous 15.8 millimeters to a new overall diameter of 18.5 millimeters, both right and left eye. And at her third follow-up visit, the patient is very happy with her current Boston Sight Scleral lenses. There's no reported dry eye symptoms, and her distance vision is wonderful with these lenses. The patient is very happy using the above the contact lens readers for near vision. Wearing time was 8 to 10 hours per day. The patient discontinued Xiidra several months earlier because, quote, it did not help relieve the dry eye symptoms and it left a bad taste in my mouth, end of quote. Visual acuities with contact lenses were 20/25 plus 2 at distance, 20/60 in the left eye. I asked the patient on this particular visit not to wear her lenses into the clinic so that I could do some auxiliary dry eye testing before taking another look at the fit of the scleral lenses. So we conducted a tear lab. Her reading in the right eye was 323. Her reading in the left eye was 328. You have to know that on the tear lab, any result higher than 308 is considered diagnostic of dry eye, and a reading of 323 and 328 is considered indicative of severe dry eye. We did a tear breakup time, which was 7 seconds in the right eye, 8 seconds in the left eye, and any result less than 10 to 12 seconds for a T-BUT test is considered diagnostic of dry eye. We happen to have an Oculus keratograph instrument in our clinic, which is both a topographer as well as a meibographer instrument. So we imaged the meibomian glands. This is an image of the right eye, and you can see with small exceptions in the upper lid, there is essentially little to no dropout of the meibomian glands. And this is the left eye, which looks, fairly normal as well. However, I have to point out to you that the fact that the meibomian gland structure looks to be intact is absolutely no guarantee that the lids are expressing the meibum during the patient's blinks. So therefore, it was necessary to place this patient on a continued regimen of warm compresses combined with digital massage of the meibomian glands. This is an illustration of the patient with lissamine green. We used 2 vital dyes in this examination, lissamine green for the conjunctival staining and fluorescein for the corneal staining. And I hope that you can see that there is a some disseminated areas of dryness on the conjunctiva, both temporally and nasally. I only am showing you the right eye image right now. And on the fluorescein, you can see that this image doesn't show too much, if any, fluorescein staining, and that's an important point. There does not have to be significant corneal staining in order for the patient to exhibit severe dry eye symptoms. However, if you take a look at the lower tear meniscus, it's almost absent, both temporal and nasal. I want to show you the edge configuration of the scleral lenses that were fit. These are Boston Sight scleral lenses. And you can see that even the tiny blood vessels, as well as the larger vessels, easily traverse the edge of the lens behind the contact lens, showing that there's no obstruction of vascular circulation, no impingement, no compression in all four quadrants. This is the same thing for the left eye, nasal aspect, temporal aspect. You can see these blood vessels pass beautifully behind the edge of the contact lens. The inferior aspect and the superior aspect of the scleral lens. These lenses really look terrific in terms of the edge configuration. Now we use an OptiView Avante OCT, anterior OCT image instrument in order to take the following images. We also happen to have a Zeiss OCT, but we didn't use it for this particular case. For those of you who may not be familiar, that black band at the top of the upper illustration on the right is the thickness of the scleral lens. The layer just beneath it is the fluid reservoir, or the space between the back surface of the lens and front surface of the cornea occupied by the tears. And then we have the cornea. I might also like to point out, for those of you who are more familiar with scleral lens fitting, that you can see some tear debris in the tear fluid. This is the edge configuration for the right lens. The tangent of the sclera easily bisect 50% of the thickness of the edge, making for a very nice landing zone scleral configuration. But it does appear that there's a little bit more than desired limbal clearance. And this situation, the edges continue to look very good, and there continues to be some evidence of a little bit too much limbal clearance in all four quadrants. When you take a look at the inferior quadrant, you can actually see that there may be some conjunctival drag or conjunctival tissue being sucked up into the limbal area. This is the left eye, and you can see that the tear debris is even more evident in this illustration. Then we have the edge configuration for the left eye in the various positions of gaze. Temporal, nasal, temporal, superior, and inferior. It was, in fact, a very, very comfortable pair of lenses. So my plan at this point was to ask the patient to add 1 or 2 drops of Celluvisc to the bowl of the scleral lenses in order to see if this reduces the tear debris under the lens, and to return to the clinic for a follow-up visit. On the 4th follow-up visit, the patient declared, "Since I started placing Celluvisc on my lenses, I do not feel like I'm wearing any lenses at all. I'm wearing the lenses 12 to 16 hours per day, and I work at computers all day." Visual acuities with the lenses were 20/25 at distance in the right eye, no over-refraction. At near with +2 readers, 20/25 at near. Left eye 20/60 best corrected, no over-refraction. Near correction 20/40 with +2 readers as well. I released the patient for 1 year and instructed the patient to return for an annual contact lens evaluation, and the patient was advised, as all contact lens patients are advised, to call the office immediately in the event of any sudden pain, redness, discharge, or change in vision. One additional note here, I'd like to again show you the illustration of the tear debris as I showed you earlier for the left eye. And yet the lower image illustrates what that same fluid reservoir looked like after applying 1 or 2 drops of Celluvisc into the bowl of the scleral lens. Our second case is not a scleral lens case today, but it's a case that I think is extremely important for us as healthcare providers to learn. The patient is a 77-year-old male patient who was actually referred to the optometry school's low vision service by a local ophthalmologist. Chief complaint, quote, "Every day of my life since my cataract surgery 4 years ago, when I open my eyes in the morning, I get severe glare and light sensitivity in my left eye. I think there is a window in my vision which I can see through, but it's surrounded by this awful haze and glare. My latest doctor told me the eye looks fine and I should see you for low vision devices. Medical history is positive for prostate, depression, hypertension, cholesterol, anxiety, and pseudophakia in the left eye for 4 years. Current medications are listed here, and I want to point out that the first 3 medications are antidepressants. Unaided visual acuities in the right eye, 20/30, in the left eye, 20/40 plus 1. Pupils were equal, regular, responsive to light, no APD noted. Extraocular muscles were smooth, accurate, full, and extensive. Motilities were orthophoria at distance and exo at near. Confrontation visual fields were full in all quadrants of quadrants, left eye, right eye. The patient asked me to turn the lights down in the room during the refraction. That was somewhat noteworthy. The right eye was plus 125, minus 125, axis 90, correcting the patient's vision to 20/20, and add a plus 250, improving vision near to 20/20. Left eye was plus 0.75, minus 1.75, axis 75, correcting vision to 20/20, add plus 250, correcting near vision to 20/20. The low vision provider's assessment: severe disability glare, post-cataract surgery 4 years ago, hypermetropia with astigmatism and presbyopia. Since corrected acuities are 20/20 at distance and near, and there's no visual field defect, no low vision devices are indicated. The plan: spectacle prescription for distance and near, full-time wear suggested, sunglass RX to reduce glare discomfort, no low vision devices recommended, return to referring ophthalmologist. You can't write this kind of a story. I was sitting in my office at my desk doing work. The door was open, and the student intern was escorting the patient and his wife past my office on their way out of the clinic. And I heard the patient express the following to his wife: "At least the doctor was pleasant, but I knew this was a waste of my time. I have heard all of these recommendations many times, and I already have glasses. Let's get out of here." Well, my background is that I have credentials in both contact lenses as well as low vision. So my curiosity got the best of me after I heard this comment, and I went to the low vision clinic to ask Dr. Toomey about the case. She expressed sympathy and sorrow for this patient, but could not help him with low vision devices. She and I reviewed the record together. I then picked up the phone and called reception and asked them to ask the patient to please not leave the building. He was already on his way out. I caught him and his wife at the front door. I introduced myself, and I asked the patient if he would be willing to come back to our contact lens clinic for a consult at no charge for the visit. I asked that the patient first be referred to Dr. Larry Bache, who is our Director of Clinical Research in the Clinical Research Department for Aberrometry. Now, this is the actual history that I've obtained from both records and from the patient presentation to me. Cataract surgery was done in July of 2017, and subsequent to that initial surgery, there were 6 office visits with the operating surgeon. The first 3 of which were spent with the surgeon reassuring the patient that his reported symptoms, which remained consistent throughout all 6 of these visits, were due to perhaps initial swelling or some healing that would have to take place after the cataract operation, that the lens was centered, clear, well placed, and the surgery was successful. On the 4th visit to the surgeon, the patient, who's continued to complain about the same problem, the patient expressed severe anxiety. He was 73 years old at the time. He was a forklift operator. He loved his job, had no intention to retire. He drove a lot of heavy-duty construction equipment. He had to give up that work. He refused to wear an eye patch because it was too disruptive to his binocular vision, and he demanded that the implant be removed. The surgeon refused to remove the implant, stating that the risk of explanting the lens was far greater than the risk of him giving sufficient time to adjust to the healing process post-operatively. On the 5th visit, the surgeon decided to send the patient to a local retina specialist for a second opinion. The retina specialist examined the patient's retina and determined there was absolutely nothing wrong with his left retina, and he returned him to the surgeon. The surgeon then decided to refer this gentleman into Boston proper at a major medical center for a second opinion. He was seen by a retina specialist there, who also determined that there was nothing apparently wrong with the retina. And the patient expressed to me that he was terrified because they actually suggested that the eye be enucleated. And to quote the patient, they wanted to kill the eye, which scared me to death. Now, I want you to know, by this time, the patient was experiencing symptoms of severe anxiety, and he was becoming depressed. His family, as well as his friends, were beginning to disbelieve him when he reported his symptoms. They were beginning to think he was exaggerating or faking his symptoms. He went back to his primary care physician, who referred him to another major medical center in Boston, Mass Eye and Ear, where he had 2 visits. On the first visit, they conducted a thorough retinal examination and determined there was nothing wrong with his retinas. On the second visit, they referred him to their electrophysiological research department, where they conducted a VEP, a visual evoked potential test, which is a test responsible for establishing the integrity of the optic nerve from the back of the eye to the occipital cortex. The findings were negative. There was nothing wrong with the transmission of the image or the retina. Now we're 18 months post-cataract surgery. The patient is absolutely despondent because nobody believes him anymore. He self-referred himself to a neurologist at a local hospital, and he had 2 tests done by the neurologist. The first was a CAT scan, and the second was an MRI. The patient was fearful that he might have a brain tumor, and yet nobody believed him. There were absolutely no abnormal neurological findings as a result of those examinations. We're now into July or August of 2019. The patient was absolutely despondent and depressed. He picked up the telephone and called a local hospital suicide hotline, claiming that he was going to kill himself because nobody believed him. They sent an ambulance to his home. He was involuntarily admitted to a psychiatric ward in a local hospital for 3 weeks, and he was only released from full-time in that hospital under the conditions that he was willing to come in 5 days per week, each week for 7 weeks for additional outpatient counseling. After release from the psychiatric hospital, his primary care physician referred him to another local ophthalmologist. He had 2 examinations with that local ophthalmologist, and both of those exams were found to have no abnormality in his retina or in terms of his cataract lens placement. But that ophthalmologist said to him at the end of the second visit, there is a clinic about a mile away. It's called MCPHS University Low Vision Clinic. I'd like you to go there. They may have some optical devices which can help you to use the vision you have left a little bit better. And that's how this gentleman got to us. So now we have taken this patient to the clinical research department, and Dr. Bates conducted aberrometry using an eye trace, an optical ray trace technology developed by Tracy Technologies of Houston, Texas. The initial topography map remains absolutely uneventful. If you take a look at the image, there's the aberrometry readings taken on the right eye. If you look at the upper left-hand corner, which shows internal, the lower left-hand corner shows corneal, and the top central shows the total RMS value, or a combination of the two. You can see that in the right eye there's evidently little or no lower or higher order aberrations indicated, except for astigmatism. And in fact, the patient did have astigmatism. If you take a look at the left eye, using an aperture setting for the pupil of 4.30 millimeters, you can see that his aberrations, both low order aberrations as well as higher order aberrations, are off the scale compared to the right eye. Right eye, left eye. This is a refractive map, a 3D refractive map showing the plane of the retina, showing that these aberrations were significant both in front of the retina and behind the retina. And when this illustration was presented to the patient at the conclusion of the test, the patient sat back in his chair and said, "I can't believe it. It's almost as if this instrument sees the same way I see. I've never had this done before anywhere." So this is the same left eye with another aberrometry image taken through a 2.30 millimeter pupil. And you can see that there's almost complete absence of any aberrations indicated using a 2.3 millimeter aperture pupil diameter. And this is the result of the RMS reading. This is his topography map, Penacam map, absolutely unremarkable, between 44.5 and 46.5. Absolutely unremarkable in the left eye. And now he's referred to the contact lens clinic, where I decided to fit him with an Alden Optical, which is a part of the Bausch & Lomb Specialty Lens Division, HP49 prosthetic soft contact lens, 14.5 diameter, 8.6 millimeter base curve, and a 49% lathe cut lens, plano power. Because his symptoms were so severe, I decided to use a 2 millimeter central clear pupil with a black annulus surround. This is what the lens looks like on the patient's eye, on the patient's left eye. And another view. The first follow-up with the 2 millimeter pupil, the patient states that glare, light sensitivity, and haziness are significantly reduced, but everything is too dark, especially indoors when wearing the contact lens. Patient also complains that his peripheral vision is restricted in the left eye with the contact lens on. Plan, reorder another clear pupil lens with a 3 millimeter clear pupil and black annulus surround. Specifications the same as the previous lens except for the 1 millimeter increase in central pupil diameter. This is a picture of the 3 millimeter lens on the patient's eye. Oh my goodness. And we then decided that we were going to attempt to fit this patient with a 3 millimeter pupil, but use a blue annulus surround in order to generate a lens which might be a little bit more cosmetically appealing to the patient. On his third follow-up visit wearing the 3 millimeter pupil annulus, he reports improved comfort with blue tinted contact lenses, with a blue tinted contact lens, no longer bothered by light sensitivity or glare or restricted visual fields. His vision is good at both distance and near. His acuities through his glasses as well as the contact lens are 20/20, both distance and near in both eyes. I have released the patient for 1 year and asked him to return to the clinic for an annual contact lens examination and return to his current ophthalmologist for medical eye care. This is a picture of the blue tinted clear pupil 3 millimeter with a blue annulus lens on the patient's left eye. This is a picture of the patient's face and both eyes on the day I released him for a year. And I think if you try hard enough, you can see, as I do, that he is smiling behind that mask. This gentleman went through a total of 67 medical visits over a 4-year period of time before he came to our clinic and had aberrometry and an appropriate contact lens designed for him.